While there have been many advances in medicine and available therapies, patient access remains a challenge, particularly for low-income and underserved communities. We are pleased to be joined by two health experts next who can shed light on the gaps in the system and what reform is needed. Matt Salo, Executive Director of the National Association of Medicaid Directors. The Medicaid program provides a healthcare safety net to more than 70 million of the most vulnerable Americans. And Alan Balch, CEO of the Patient Advocate Foundation. The foundation provides services to patients with the goal of eliminating obstacles that they face while seeking quality health care. Joining them for this conversation is Peter Sullivan, The Hill's healthcare reporter. Peter, Alan, and Matt, thank you.
All right, well, I'm going to dive a little more in with a panel now after hearing from the commissioner, and then we will open it up to audience questions in the last 5 minutes or so. So if you want to be thinking of any questions that you have, go for it. But I guess I'd start with just kind of a broad question that I guess we could talk for all day about. But I mean, start with Alan. I guess, like, why do you? I mean, there are obviously patients who are having trouble, getting access to the medicines they need. Why do you think that is? Is it just as simple as expense, cost, or is there kind of more complicated things in our complicated system that also hinder patients from getting medicines?
Yeah, so real briefly, just so you folks know where I'm coming from, we at Patient Advocate Foundation serve low-income patients, most of whom have coverage, who are seriously ill, and they're having some access or affordability problem. And I think we all know that we've created the world's most expensive and most complicated healthcare system, and ergo, the problems related to access that patients experience, particularly low-income patients, are similarly very complex. We actually document the reasons why patients are calling us, and we have a system that actually have a typology for about 200 different types of unique problems that patients are facing. And they're usually, and I think you mentioned access, but access and affordability are intertwined, as well as coverage. So it's just that complexity alone is huge. But usually patients are calling because they have some access problem, they've been denied coverage, or they cannot get to coverage. And we haven't solved the coverage problem yet, which is why Medicaid expansion is so important. But we also have not obviously solved the affordability problem, and that's probably about 60% of the reason why patients are calling, is they can't afford something in the system. And it's not just one thing. I want to be clear about that. For seriously ill patients, it depends on where you are in your disease and the type of treatment. So if your treatment is primarily medications, then it's the medications you can't afford. If your treatment is surgery, it's your surgery you can't afford. If you need a radiology appointment, it's that you can't afford. So it's complicated and complex for patients. And I don't know what the answer is, but I do know what the problems of day-to-day patients look like, and it's pretty tough.
Mm-hmm. And I guess, Matt, I mean, in terms of Medicaid, and maybe the issue, I mean, on the patient level, if you have Medicaid, I assume you have pretty good coverage in terms of covering the drugs. Is maybe the issue more the strain on the system as a whole, the Medicaid program as a whole, in terms of drugs?
Yeah, in short, yes. And I think Alan's exactly right when he talks about the nexus between affordability and access. I mean, cost equals access. Now, there's a different problem in the Medicaid world in that it's not really so much the cost to the patient because, for the Medicaid beneficiaries, all 70+ million of them in this country, the actual kind of point of contact cost is essentially zero. But it becomes a broader issue because it is state government where Medicaid is on an average state 25–30% of the state budget. It's the cost to the state, it's a cost to the program as a whole that is making very, very expensive treatments, no matter what they look like, difficult to figure out how to cover. And so it's a different lens on the same problem. If we can reduce the cost of the treatments, of the interventions, we can make them more accessible.
And I guess we've had some kind of big new expensive drugs coming on the market. I mean, how do you kind of, on the one hand, some of these are really cure some really tough diseases. I mean, there's a lot of value there. On the other hand, they can have a high price tag. So I guess how do you kind of balance that equation? Either of you, yeah.
I'll jump in. I mean, I think there's an inherent tension between access and affordability, and that's just always going to be there. And so the other thing I didn't mention, and we do ask our patients, what's important to them, what are they looking for, and patients are seeking highly personalized therapies that have clinical benefits as well as quality of life benefits. So that's the other piece of this and that's what makes it tough for patients is oftentimes when you sort of titrate against access, it affects affordability and vice versa. So that's the challenge is patients definitely patients want what we all want, which is they want access to really innovative and effective therapies, not just from a clinical perspective, but from a quality of life perspective. And they also want access and they want it to be affordable. And those things are in tension. And in a tension, they're hard to balance those things out. And I don't have the answer, but we'll eventually get to it. We do have some ideas about how I think the big disconnect right now, or one of the big disconnects, is while the science is advancing rapidly towards incredibly personalized and targeted therapies, we haven't figured out similarly how to innovate in the reimbursement and then the care delivery environment to also deliver those therapies in a highly cost-effective way. I don't know that it's not going to be cheap, but I do think there's a way to deliver it in a cost-effective manner. And for you political scientists and economists in the world, you kind of know the difference between less expensive and more cost-effective.
Mm-hmm. I would just say, I think the way that I would frame it very similarly, we're kind of in we're in a 21st century cures world, where a very clear national federal policy decision has been made, and I think it's a good one, that we want to drive innovation, that we want to create, that we want to bring things to market to treat conditions in patients that were hopeless or helpless before. This is a good thing. Mm-hmm. But where the 21st century cures kind of solutions stopped was at that point of figuring out, okay, once we get innovation, how do we pay for it? How do we afford it? How do we make this affordable to the system? That, to me, is the next thing that absolutely has to happen.
Right, and part of that is not just how do you reimburse for it, but actually how do you make sure you're putting the right care to the right patient at the right time. So that's part of the cost effectiveness, right, is you don't want to give patients expensive therapies that aren't going to work for them, but you also, by the opposite of that, you don't want to give patients therapies that aren't going to work for them and they're going to be ineffective.
And maybe Alan, from the patient perspective, when someone just shows up at the pharmacy counter, what's kind of have you found that price that they're paying directly to the pharmacy is what they're really caring about, or how does that kind of relate to this overall discussion of costs?
Yeah. So when we ask patients what's important to them when it relates to affordability, obviously the thing that's most important to them is what they pay out of pocket. And I think it's important to note from patients, what they pay out of pocket is not just what they pay out of pocket within their insurance benefit design, it's what they're paying out of pocket for everything else related to their care, and that encompasses things like time off work, transportation, child care, caregiver burden. So we use the word out-of-pocket expenses, indirect or direct, they're all direct cost to patients. So my point is, it's not one cost. So when we ask them, what's important to you, it's what they're paying out of pocket is what's most important to them and what they're worried about, and that's the information to which they want access. But they do at lower rates, but at least for our patients, they do also care about the overall cost. But when we ask them what's most important, 90% say the cost to me. We also ask, do you care about the overall affordability, the cost to your plan, the cost to the government, and about 65, 70% say they care about that as well. So it's not either or, but I do think the thing that patients first and foremost care about is what's the cost to them. And again, that cost for low-income patients, it's whatever the last bill you got, whatever the last trip it is that you took, whatever the last day you took off work is the thing that you can't afford.
And Matt, I guess from that overall perspective, I mean, do you think that there needs to be kind of more discussion of new payment models? I mean, especially in Medicaid, or is that do you think the Medicaid rebates are working pretty well? Is this something that should transfer just to other kinds of insurance? Or
I think we definitely need some new thinking. I mean, I think most states would generally argue that for the most part, the current system where we cover all drugs and we get rebates and get a good price, is working pretty well. But again, kind of going back to this 21st century cures world, I think that has so fundamentally altered the landscape and will continue to alter the landscape that we really need kind of a new covenant. We need a new way of dealing with the tsunami of innovation that's going to come. And I would even argue there are probably two different ways to think about it. One of which is, and again, Medicaid is no stranger to dealing with, obviously by definition, low income, very sick, very expensive, medically fragile populations. We cover a lot of people with hemophilia for whom the cost of their care is, more than $1 million a year every year, and the whole spectrum. There's two things that I think we're going to be challenged with. The first is kind of the big public health kind of widespread impact innovations. The big one that obviously hit us a couple of years ago was hepatitis C. No one was prepared to figure out how are we going to pay for something that was going to impact potentially, the cost of the drug, if you talk to ICER, is value. Makes sense. I get that. But there were potentially 1 million Medicaid beneficiaries, to say nothing of individuals who were in the correction system, who needed to be cured. That represented kind of a staggering amount of money. And I remember the folks in Florida doing a cost analysis when this first came out and said, for the cost of what it might, for the price or the cost of treating hepatitis C, we could build 500 elementary schools across the state of Florida. So it's that kind of thing that, it's not the patient cost, but it's the cost in a very real sense, in a broader way. So how are we thinking about those big blockbuster, whether it's a public health threat like hepatitis C, or whether it's, treatments that are coming for sickle cell or Alzheimer's, things we want to treat but are going to be so impactful across the nation, we're going to need to think differently about it. And then the other piece is, to Alan's point, the tsunami of innovation around personalized medicine, biologics, gene therapies that are going to be extraordinarily expensive, and I don't know that we've really got a handle on the clinical effectiveness just yet, because the whole point of 21st century cures was speeding to market a lot of these items. So we're going to have to think differently about how we treat these.
Well, and just to piggyback on that, first I would add not just to the clinical effectiveness, but what we're learning about a lot of these personalized and targeted therapies is they have other benefits that are really valuable to patients around things like transportation, work disruption, caregiver burden, that go beyond sort of the traditional clinical benefits and endpoints that do need to be included in our calculus of how do we value things, because again, patients are paying not only out of pocket in lots of different ways for these therapies, so what's valuable to them and the costs and benefits to them have to be incorporated into the way we calculate these things. But I think beyond that, when we think about how do we really deliver and reimburse for personalized medicine, that's another incredible opportunity for innovation. And I don't think it's the type of policy innovation that you normally would see. It's really a multi-stakeholder collaboration. I think it's plans and providers and patients and hospital systems and doctors and nurses and NPs working together to figure out how do we actually create a system that's designed to truly get the right patient to the right care at the right time, in those areas where you really have highly targeted therapies in diseases where it's not clear what the right medication is or the right therapy or the right treatment is to give a patient. There's lots of variation, and that variation exists because of not just the clinical benefits, but also the variation in quality of life that those different therapies may bring. And that's where I think you really need to focus on a different way of thinking about utilization management, for example. We don't necessarily, there are places where utilization management makes sense, and there are places where it needs to be rethought, if you will, whereas whereby you might have a really robust system and an evidence-based system of shared decision-making, right, and care planning that's supported by decision support tools like a pathway. And then you have tied to that all sorts of measurement, but particularly measurement that matters to patients around patient-reported outcomes. And if a patient and a health system go through that time and effort to really get to understand the patient, what's important to them, and make sure that the therapy that they're providing to that patient, or maybe no therapy, is the right care for that patient, including the cost of that therapy, then that should be authorized, that should be approved, and then you put that decision at risk. You put the hospital at risk, you put the medication at risk. You can actually use sort of what we're doing in the alternative payment model to put that type of shared decision-making and person-centered care planning at financial risk, and you reimburse it, but you, like I said, you put risk in there to incentivize for actually trying to go through the time and effort to make sure you're getting the right care to the right patient at the right time, and you try to disincentivize or there's some punishment if you make a mistake in that regard. And the therapies and the diagnostics actually really are becoming pretty capable of being able to identify which patients are more likely or most likely going to respond to different types of therapies. And that's the innovation on the medicine side. Mm-hmm. We're just not seeing that type of innovation on the delivery and the reimbursement side.
Yeah, and I would actually like to kind of follow up on that a little bit. And I agree, but let me add a kind of a caution or a caveat, which is that, there's a difference between kind of like how we think about the value of a cure with respect to, what the manufacturer is bringing to the table versus how the payers, whether that be the person or the state or the federal government, deal with it. So in an example of an Alzheimer's treatment, let's say we have an Alzheimer's cure, and I hear, pharma talk a lot about, well, think of the value of the cure if we cure Alzheimer's. Half the people in nursing homes have some kind of dementia. All those people are on Medicaid. Think of all the savings you could realize from not covering nursing homes. Right. Think of all the benefit to the workforce for those people who can work longer, or the unpaid family caregivers, and that's all true. These are all great things. These are societal goods, and I think people should be incentivized and rewarded for solving societal crises. But I will tell you that if the answer is, let's add up all the dollars in this value and charge Medicaid for it, that ain't gonna fly. Yeah. That is not sustainable. And so I'm happy to make sure that the manufacturers get their due. I'm just saying that state government is a very, very shifting and uncertain basis for which to shoulder that entire burden.
All right, I think we want to get some audience questions, so right there. Well, there's a mic, wait for a mic to come around. And please just say your name and your affiliation.
Carl Schmidt, the AIDS Institute. One of the patient affordability issues is high coinsurance and high deductibles by the insurance plans. And to help patients with that, many of the drug manufacturers offer copay assistance, but now some of the PBMs and insurance companies are not allowing that to count towards the deductible. Just wondering, perhaps Alan could comment on this, and what's your comments on that? Thank you.
Yeah, I mean, it's a difficult subject. I think what we have now is a system, as I mentioned when I first opened up my comments, there's certainly healthcare is expensive for anyone who's trying to experience it, but for low-income patients in particular, it's the $20 copay. It's the trip to the hospital. It's the emergency room stay. All those things are difficult for them to afford. We've created a safety net system that actually helps to patchwork that against that. And part of it is sort of what we have in the federal safety net, Medicaid, the low-income subsidy programs. But also there's a charitable piece of that as well that's provided by charities like mine, and also some of the charitable and copay assistance that the manufacturers provide directly. It is not a permanent solution, but it's just sort of it's a result of the way the system works. So if you have high out-of-pocket costs for patients, one way to alleviate that is to actually give them direct assistance related to that copay. So without a different solution for how to create affordability for patients, I think that system has, although not perfect, has actually worked to help fill a gap in affordability for a lot of patients. I will say that a significant percentage of patients who call us seeking financial help, that the place we ultimately end up finding it oftentimes is from the support that the manufacturers are providing in the form of discounts and coupons. And I know it's not perfect, but it's actually a pretty, and I know that the purpose of that often is not a safety net purpose, but it does serve a safety net purpose for those patients that aren't able to access or afford their medications by some other means, and they do have a high out-of-pocket cost. I get why that tension exists. It goes back to what I said at the beginning, but that solution is something that has worked well for patients, and if you take it away without providing some alternative, like significant Medicaid expansion or expanding the low-income subsidy, I don't know, you're gonna leave a lot of patients unable to afford their medication and caught between sort of the work that the insurance plans are trying to do to manage their budgets and make their healthcare affordable, and the work that the manufacturers are trying to do to try to bring innovative therapies to the market. So patients are just stuck in the middle, and I think that's just one repercussion of that tension.
We only have like a minute, but let's do a fast question up in the first row. Hold on, it's for the, yeah.
I'm Abdul. I'm an investor and business model inventor. I'm wondering, is there an innovation platform? So you mentioned hepatitis C, for example. 1 million patients have it, and we can cure them through those drugs that are very expensive. So I figured a way to cure them all by using specialty finance to actually buy the patent. But when I try to connect with states, I can't get access to data. So how do we take advantage of lots of people all across the country that could have ideas, but, is there any platform where we could come together and really push for innovation that doesn't cost any more money?
I guess I'm not surprised that states are not willing to give up, vital data about the health status of their patients to anyone who's asking. But I think, at CMS at the federal level is probably the best place to start for conversations around innovation like that. At Center for Medicare, Medicaid Innovation, or just come talk to us and we'll figure something out. But yeah.
All right, thanks. I think that's all the time we have, so thanks to our panelists.